All right, we'll go ahead and get started. It's 12:45. I know people are still coming in, but I'm sure this will be a lecture with tons of questions. There's lots of interest in this. So I want to welcome everybody to our April MTAC conference with Dr. Tibor Nagy. He's one of our EMS fellows at Carolina's Medical Center, and he's going to be speaking on pre-hospital blood administration. But first, real quick, I just want to announce and remind everybody of our upcoming Metrolina Trauma Symposium on May 15th and 16th in Charlotte. I'll put the link for registration and the schedule in the chat box, as well as a link for our evaluation for our for this conference itself that we're having today. Dr. Green will be joining us shortly. He had to do another meeting at the same time, so he'll be on shortly, and just ask your questions as they come up or in the chat box. Thank you. Dr. Nagy.
All right. Well, thanks so much, Scott. Good morning, or good morning. Look at that. Good afternoon, everyone. So I'm Tibor. I'm one of the EMS fellows here at Carolina's Medical Center at our Department of Emergency Medicine. Today, I want to present to you guys about the challenges and trends of pre-hospital blood transfusions for trauma patients. So pretty straightforward.
I think you're muted now.
There it is. I think I muted myself. Let me just go back one slide here, guys. Just like I said, I'm Tibor. I'm one of the fellows here at Carolina's Medical Center for EMS. I am an emergency medicine trained physician. I'm going to be talking to all of us here about the trends and challenges in pre-hospital blood transfusions in trauma patients. Now, I have no financial disclosures to mention to anyone. I will be talking about certain brands of products, agencies in general, none of which I have any financial relationship with or preference. These are all just using for the teaching points throughout the presentation, okay? Now, the objectives for our grand rounds today, I have several key things that I wanted to touch on regarding blood. First, I kind of want to trace our historical development of blood transfusions from very early on into the present to why that is important to today's EMS world. Then I kind of want to discuss the challenges in our modern advancements in pre-hospital blood transfusions. I want to focus on kind of systems, logistical hurdles, and strategies. I will be talking about some of the medicine of blood in general too for trauma. And hopefully by the end of this session, we can kind of gain some insight into how these practices are integrated into civilian EMS and kind of the ongoing challenges that we're going to continue to face as we move on. And most importantly too, right, we're in a room full of key stakeholders and healthcare leaders from across our region in general, and who are going to be crucial to support a program like this if there is a wish to start using pre-hospital blood for trauma patients, for example. All right, so our first kind of set of kind of research here, evidence-based, for every 1 minute of delay in pre-hospital resuscitation, we have about a 2% increase in 30-day mortality in trauma. So this statistic kind of highlights the need for rapid interventions in trauma in the pre-hospital field, right? And one of those things that we can use is pre-hospital blood. So pretty remarkable numbers there. Now, I don't want to spend too much time necessarily trying to convince you that blood is important in trauma care, right? Because we already know that. The headlines for example, these very recent research papers on pre-hospital blood kind of say it all. The outcomes are kind of clear on how important blood can be for trauma and trauma in the field. So instead of kind of debating if blood matters, I kind of want to focus on the real challenge, right? Which is how can we get it into the field from a lens of an EMS physician myself. Now, I'm going to have these slides here periodically throughout the presentation. These are kind of little question things. You're more than welcome to put your answers in the chat, and I can kind of see some of the answers there, and so can the crowd who's here. But also, if you want to mute yourself, please do. So the first question that I have for the audience here is kind of a trivia question there. When was the first recorded successful blood transfusion? What year did the first successful blood transfusion happen in general? I'm not just talking about trauma. I'm talking about just blood transfusions across medicine, the history of medicine. All right, guys, and like I said, you're more than welcome to throw it in the chat, or if we want to mute ourselves, that's also perfectly fine. Yeah, I see kind of 1860s, not too far off. So the actual first recorded blood transfusion in history that we have recorded was in 1665. So for historical reference, that was England had just installed New York City as a municipal government. So it had just switched from the settlement of New Amsterdam by the Dutch into New York City. So it's been a long time that we've known that, you know, we've been trying to use blood products as humans in general. All right. Now, the concept of blood transfusion was very revolutionary and very rudimentary at that time, right? In this, you know, before the 1800s. So the experiments, the transfusions were experimental. They were often between animals and humans. In specific, you know, even in the US, we were using milk from cows in order to transfuse patients at that time. So these centuries kind of set the stage for the medical exploration of transfusions as kind of this life-saving procedure that we can use. So as we move on from the 1600s to the 1700s to the 1800s, we kind of saw significant milestones, right? So we had the discovery of blood types and development of antiseptics, and we were improving the safety of the efficacy of blood transfusions in general. So this period kind of marks the beginning of blood transfusion as kind of a scientifically endorsed practice. And often Dr. John Baptiste Dennis himself was credited with the first successful blood transfusions to a human. So it's kind of crazy that we were using milk at some point in order to do that. So in the early 20th century, we kind of established blood banks and we started using anticoagulants that kind of revolutionized blood transfusions. So these advancements kind of made the storage of blood more accessible and safer. And it was kind of paving the way for a broader application in medical terms, including trauma care. And importantly here in about 1914 is when sodium citrate, for example, came into the world of blood transfusions. Now, during the 1930s and 1940s, we were at war once again. So we had a huge demand for blood once more. Kind of this area kind of witnessed the mass coordination of blood donation campaigns, and we established military blood banks, which kind of improved the civilian medical practices as well at that time. And in the 1940s is when the U.S. government established kind of this national blood collection program. Now, very briefly, post-war war, we're kind of moving faster through history. We're kind of focusing on even refining the techniques even more. We were kind of expanding the understanding of blood component therapy. And this decade kind of also saw the introduction of plastic bags. So it wasn't until the 50s that we moved away from storing our blood in glass bottles, essentially, to plastic. So there was kind of a leap that kind of enhanced the blood transfusion practice at that time. Now, in the 60s and 70s, I want to call this kind of the platelet era, even more of the component therapy themselves. So this is when we start to recognize platelets as kind of a way to reduce mortality and hemorrhage in certain cancer patients. And we were even kind of demonstrating the feasibility of longer storage of platelets at room temperature that kind of were revolutionizing transfusions at that time. Now, this is kind of the era foundation of modern EMS system as well, which we'll dive into in just a little bit here. Now, once more, kind of a quick little question here for our chat. You know, if anybody knows what city is credited with in the United States, what city in the United States is credited with the birth of modern EMS systems? I don't know if anyone kind of knows the answer to that one. Like I said, more than welcome to drop in the chat here, but I don't want to spend too much time. Yeah, I kind of saw the right answer over there. So correct. And I'll talk about Pittsburgh here in just a second. So let's kind of take a leap back and look at what emergency care kind of looked like before our modern EMS systems. So before the mid-1960s, there was 911, right? If you were seriously injured, you kind of had to call a 7-digit emergency number for your city, and you had to know that number. So dispatch itself at that time would send help, but it wasn't usually trained medical professions. We were talking about police officers and firefighters. And like I said, not to discredit our first responders at that time, right? But at the time, we were not emphasizing the medical training. So these, police officers and firefighters were responding with little to no medical training to medical emergencies. So the consequences by 1965 were staggering. And, around 49,000 Americans that year died in car crashes, which for that time, that is an astronomical number. So it was about 5.36 deaths per 10,000 cars. So that's a lot. So people weren't just dying from injuries, right? They were dying because they didn't get timely, appropriate care before reaching the hospitals. But also I want to mention, right, it's not just about getting the patient to the hospital. Obviously, you have highway safety, you have car safety, all sorts of things that also played a role into kind of, survival of traumatic injuries, especially in car accidents there. Now, by the 1970s, there was kind of this transformative program emerged in Pittsburgh. So we have the Freedom House Ambulance Service. So this was staffed primarily by Black men, and it wasn't just revolutionary because of who they were, but because of what they were doing as well. So the Freedom House became the model for the nation's first EMS training program in 1975. So just for context, 1975 is the first year that Saturday Night Live aired on NBC. So not that long ago. So the EMS systems that we know today, kind of staffed by trained professionals with protocols in trauma, cardiac arrest, and medical emergencies in general, were largely born out of this era. So we had this group of Black men, of also visionary physicians that were kind of stepping out from the hospitals into the streets, and they're kind of pioneering those strategies in order to help our patients, survive to hospital treatment, especially in trauma. So this is what's credited with the birth of modern EMS. And, if anyone has read this or wants a good read, American Sirens by Kevin Hazard is a great book regarding the Freedom House folks that started kind of the modern EMS. So I highly recommend if you have the time and you want a good read there. Now, in the 80s and 90s, we're kind of moving along. This kind of was when EMS systems are truly maturing as well, kind of the modern EMS systems. And these decades were kind of characterized by questioning our previous methods, right? And we were kind of developing even more standards, which including evaluating the effectiveness and safety of pre-hospital blood transfusions. And as we remember, if you were alive that era, you got to remember that was kind of when our AIDS and our HIV epidemic kind of came about. So that was a big deal for blood transfusions in general at that time. So I'll do a quick little recap for all of us. So we went from animal to human transfusions to kind of life-safe fielding intervention. So we're not using any more milk by this point. We were kind of, we had discovered blood types and anticoagulants, and we're making storage and compatibility possible based on research. Conflict in general, right? So world wars were accelerating transfusion science and logistics. We were introducing blood banks, plastic storage, and component therapies in general for blood. And then this is when we have the birth of modern EMS. And just to highlight again, right, this is a more recent thing than we think. And this is why it kind of plays into blood in general. Now, kind of that journey to pre-hospital medicine, right? So how did the blood get to us per se? Kind of the way we know it now. So as we move through the 80s and 90s, so our EMS systems are continuing to grow, right? So we're not just growing in size, but we're growing complexity of what we got going on. So our protocols are becoming more refined, and we're starting to question kind of our long-standing assumptions about trauma care and pre-hospital interventions at that time. So it wasn't just a time of evolution, but we were also kind of reflecting on what we were doing. So it was during this time that a critical question began to take shape. If blood is a cornerstone for resuscitations in the hospital, why are we waiting to get to the hospital to give the blood, right? So this question is setting that stage for the new frontier. So this would challenge our norms, it would challenge our comfort zones, right? And even regulatory frameworks. So I kind of want to dive into that journey a little bit and kind of talk about that journey toward bringing blood into the hands of EMS providers or EMS clinicians in general, before the patient even gets to our EDs and our trauma base. Now, kind of moving a little bit history once again. By the 1980s, we had kind of that standard of care for our hypotensive trauma patients. So whether our injuries were blunt or penetrating, didn't matter. The response was the same. We were applying these kind of anti-shock garments, also known as PSAGs or mask suits, and we were initiating aggressive fluid resuscitation. So what fluids were we using, right? We were using isotonic crystalloid fluids, which could be lactate ringers or normal saline. And then we have some newer alternatives too, which include plasma light or normal salt at that time. So the goal was pretty straightforward, right? We are normalizing blood pressure and we are reperfusing tissues. I can get behind that logic. It makes sense to me. Now, the logic behind this, why they were doing this, came from these animal studies that showed that combining blood with crystalloid fluids were reducing mortality after massive hemorrhage. And at that time, we had the rise of air medical transport as well, and we were increasingly have more capable ground EMS units. So these interventions could now rapidly be delivered to our patients in the field. But the thinking was, right, so if we could restore perfusion early enough, we could save lives. So by the late 1980s, we had these immediate crystalloid infusions became nearly universal in trauma care. So whether we were on the scene or en route to the trauma center or even at the trauma center itself, it was a significant kind of leap forward in EMS, kind of representing this era of protocolized and aggressive pre-hospital management that we can do for our patients who are very sick. Now, kind of after years of kind of this widespread adoption of kind of the the revolution that we were bringing on with the anti-shock garments and the crystalloids, we kind of began questioning that knowledge in the late 1980s into the early 1990s. So specifically, why are we doing it this way? So the clinical trials that kind of surged at that time started to suggest that the interventions that we were doing, especially in patients with penetrating injuries and ongoing internal hemorrhage, we probably weren't helping as much as we thought. So in fact, we actually may be doing harm. So what was the troubling reality regarding what we were doing, right? So while these measures were successfully raising blood pressure, which makes sense, they may actually have increased mortality in certain trauma patients. So we're talking about our penetrating trauma in general. So this was a shocking realization for that time, and it kind of turned decades of this dogma that we were doing on its head. So what happened is that the original evidence that actually was backing the pre-hospital fluid resuscitation came from animal studies in the 50s and 60s. But the models that they were using this, or how they did their research, had a major limitation. So the blood was removed in large volumes from those animals. And yes, bleeding had already stopped before the fluids were given. So the experiments kind of didn't mimic real life trauma, kind of where that bleeding continues while the fluids are being administered, right? So the difference turned out to be critical. So when you pour fluids into a patient who's still active bleeding, you may actually dilute clotting factors. You may raise the blood pressure enough to even dislodge fragile clots and actually worsen that hemorrhage. So this was kind of the start of this major philosophical and clinical shift into trauma care. So one that would kind of lead us towards more of that permissive hypotension and eventually even the reintroduction of blood products to the field. Now, by the 1990s, by the late 1990s there, we kind of had that turning point into trauma resuscitation. So there was kind of that growing skepticism about the traditional interventions, kind of like the crystalloids and the anti-shock garments that we were talking about. And we kind of began designing new experimental models to kind of correct that flaw from the 50s and 60s on kind of how we got to the point where we were at that time. So specifically, we wanted to kind of understand that uncontrolled hemorrhage prior to operative intervention. So these studies were kind of game changers at that time. So we were showing that giving the isotonic fluids, even hypertonic at the time, actually, before the bleeding was surgically controlled, could actually be very harmful. So we were demonstrating that with evidence-based medicine. So unlike the early animal models, where the bleeding had already stopped, we were kind of stimulating ongoing active hemorrhage, and the results were eye-opening, right? So first, the fluids that we were giving were perhaps causing what we call the hydraulic acceleration of hemorrhage. So in simpler terms, we were raising the blood pressure too early, and we were pushing the blood out faster from these injured vessels from the trauma. So second, it kind of caused that mechanical disruption of the clotting cascade. So we were dislodging these fragile early stage clots that hadn't yet stabilized with fibrin. And third, there was a dilution. There was a dilution component from the clotting factors. So we were weakening our body's ability to actually form effective clots. So in hindsight, we know that this now played a huge role into survival of our trauma patients as well. So we were kind of shifting the focus from this aggressive fluid replacement towards kind of strategies that were minimizing bleeding risk until we could definitively get hemorrhage control in a more controlled setting like the trauma bay and the OR. Now, I want to get very granular here, and this is when, I bring us back to the early days of medical school here. So as we were entering the 1990s and 2000s, we kind of began looking at, beyond blood pressure in our trauma and bleeding. So we were turning attention to what was happening at the microscopic level of hemorrhage in general. So we were kind of looking at that interface between blood and the blood vessel wall itself. And that's when we kind of have the glycocalyx layer kind of entered into the spotlight from a microscopic level. So many of us at that time, I was not alive. I was, 4 years old in 1994. So we hadn't even heard of at that time what this was. So this glycocalyx is this kind of very fragile gel layer that kind of lines the inside of our blood vessels, and it plays a critical role in maintaining our vascular integrity in general. So it's going to be composed of those glycoproteins and proteoglycans, and it serves as a protective barrier. So we are kind of helping regulate vascular permeability with the glycocalyx, and we are preserving kind of that shear stress response, and we are also preventing clot formation inappropriately. And here's why this is a key discovery. So our traditional resuscitation strategies, like we talked about, the large volumes of isotonic fluids, were actually damaging this layer from a microscopic level. So the layer was being eroded, and the consequences included things like leaky capillaries that are going to worsen edema. We are disrupting platelet function, and we are impairing coagulation. And with all of these things together, we are even increasing a higher risk of multiple organ failure in patients with massive hemorrhage or hemorrhage in general from trauma. Now, more recently, the research has shown that blood products, particularly blood in general, and plasma, are far more effective at preventing damage to this layer. So in other words, that kind of blood-based fluids are not just replacing volume, right? We're also preserving that microscopic structure that keeps our patients, that can help keep our patients alive. So understanding this kind of reshaped our view of trauma even more. So it's not longer about blood pressure, right? We're also talking about endothelial health and coagulation and organ protection at the cellular level. All right, so as we're kind of moving forward here, I'm showing you kind of this graph. It's kind of halfway chopped because I'm choosing to show from 2000 forward. But by the end of the 1990s, our things were clear. We were rethinking our approach to trauma. So we are flipping that old paradigm of filling the tank with crystalloids by kind of that more cautious damage control mindset. And this graph here specifically comes from a paper from Lamers and Holcomb, and it kind of gives you that timeline that I'm kind of walking us through here a little bit. So in the early 2000s, as we entered that era, the U.S. military experience, and specifically in the Middle East, is kind of reshaping trauma even more. So survival on the battlefield was about rapid hemorrhage control. So tourniquets, once considered a last resort, are becoming standard issue. So the military is also deploying kind of clot-stimulating dressings, hemostatic agents, and other tools to stop that external bleeding with this unmatched speed and effectiveness. So meanwhile, we're also turning attention into kind of that internal bleeding. So that's when we have things like TXA coming into light, right? So the crash trials are showing that even early TXA can significantly reduce mortality, but is also starting to highlight, which is an important point here, that timing is everything in terms of our trauma. So we're showing that kind of the late administration of interventions could actually worsen outcomes. So the message was pretty clear, right? Let's get the early intervention in order to save lives. And I don't want to go into depth about some of the stuff that goes on with TXA that we know now. Now, as we're evolving, we are kind of recognizing that the giving only red cells, so blood is becoming more part of this. It's not enough. So we want to talk about that balance. That balance of resuscitation also matters. And that's when around the early 2000s is where we introduced the concept of damage control resuscitation. So damage control resuscitation, we're trying to avoid that lethal triad of trauma that we know, right? So hypothermia, acidosis, and coagulopathy. We were kind of promoting that one-to-one transfusion of, part red cells, plasma, and platelets to kind of support that clotting and to stop that bleeding early. So we were replacing the kind of high volume, definitely the high volume crystalloids, even into high volume blood, which sometimes could be seen at that time up to 8-to-1 ratio to kind of try to improve what was going on in the patient. So now this damage control resuscitation with balance resuscitation are improving clotting, perfusion, and the outcomes in active bleeding. So this originated in our military/trauma centers, and we are spreading now this into the EMS civilian world. So what started in the trauma bays and battlefields now is out in the streets. And because when it's coming to hemorrhagic shock, the earlier we act, we know that the better chances of survival. And that's a recurring concept with all of this. Now let's kind of take a brief recap here. So Iraq and Afghanistan kind of redefined trauma here for us in the US. So we're having that external hemorrhage control. We have our tourniquets, our hemostatic dressings, our clot promoting agents, which are a much easier thing to get out into the field. And then we have internal bleeding management, right? We have TXA emerging as a game changer. We have the, kind of this the confirmed survival benefits of TXA, the important timing of delivery of these things. We have the concept of damage control resuscitation. So we have shifted away from crystalloids into blood products, into more refined blood products that we can do. And then we also have in that civilian adoption now becoming a reality. So we're paving the way, and kind of will be the next topic, which would be kind of whole blood and not just component therapy. So what about us, right? We have all, what about us in EMS? So we have all these groundbreaking advances that are coming out of the military, but the natural question is still there, right? What about us? What are we doing as civilian EMS? So how do we in civilian EMS kind of take these battlefield strategies and bring them to the streets, the highways, and even the homes of our patients, right? And it's important to remember that civilian EMS, we operate in a completely different environment. We don't have, medics carrying blood in armored convoys. We have supply chain challenges. We have medical oversight boards. We have budget limitations, and we have regulatory hoops to jump through. And not that the military forces don't have that, but we have our different flavor of all these kind of hurdles. So the question is still there, right? If we know that early intervention with blood products are saving lives, why are we still waiting until the patient hits the trauma bay to give it? I kind of want to open this up here for a couple of minutes to our audience in general. I'd love to hear from the group here if anyone wants to speak up and tell us what is some of the agencies that are represented here today are currently doing with blood in the field, and if there's anything at all, right? We just may be with no representatives from organizations in North Carolina that are doing blood. So I want to give like a minute or two here if anybody wants to speak up and kind of tell us what you got going on in your agency or your region. All right, you don't have to necessarily kind of speak up. You can also throw it in the chat if you want. It's kind of up to you. All right, there it is. So we have Wilkes EMS, 5th program in North Carolina. That's good to hear. And and I'll talk a little bit about that as well, kind of what that looks like in North Carolina and our region itself. So good. One of the first 100 in the U.S. Yeah, I think it's just MCA that carries blood. Got it. Iredell, Mecklenburg, Union Stanley, anyone else? Thanks, Scott. But yeah, we don't have to spend too much time on that. So I kind of want to keep going with our conversation here. So I wanted to demonstrate, right, the chain of survival and trauma. And you can see here that EMS is literally in the picture on the left is at the center of it. By the way, they kind of made the chain there. So from hemorrhage control to airway management and kind of rapid transport, right? What we do in the field is gonna set the tone for everything that's gonna follow what happens once the patient actually comes to us in our trauma centers, in our hospitals. So early decisions, early interventions, and early blood are all kind of links in this chain that can mean the difference between life and death for our patients. So just a reminder that EMS is not just a bridge to the hospital, right? We are a critical piece of a patient's care. Now, this table here is kind of highlighting kind of the key differences between traditional component therapy and low titer O positive whole blood, which we'll go into discussion here a little bit. So with components, we are juggling multiple products. So we're kind of juggling those RBCs, plasma, and platelets, each with their own kind of storage, compatibility, and administration requirements. Now, whole blood kind of simplifies all of that. So it's going to give us kind of that volume, oxygen carrying capacity, and the coagulation support that we will need for our trauma patients in the field, and platelets all in one unit. So those things are important. So whole blood is not just easier logistically to think about it, it's also more physiologically effective, especially in the field. And that can be kind of one of those kind of buzz things to talk about. Now, we kind of seen how O positive blood, low titer compares to component therapy. So let's kind of talk about this low titer O positive whole blood and how this is kind of changing the game in EMS. So it is universally compatible for most of trauma patients and logistically simple, like I talked about, and it supports everything that we learned about early balance resuscitation and damage control resuscitation. So this is not just about stopping the bleeding, it's also preserving kind of the life from the very first contact in our chain of survival for traumas. So EMS systems across the country are stepping up to kind of carry the whole blood into the field. And because we're not waiting now to save lives, right? We are starting into the streets when we show up. And, we're showing that now we're seeing the blood in helicopters, EMS, we're seeing in supervisor SUVs and ground ambulances, and even sometimes at some mass gathering events, we have places out in the United States that have blood ready for exactly this issue. Now, let's get a little bit more granular. Low titer O positive whole blood, right? It's the go-to option. So why are we moving away from relying solely on O negative that would be truly universally compatible with everyone, not just specific populations? So O negative blood is considered the universal donor, but it is extremely rare. So only about 8% of the US population is O negative. And as we go globally, that number is even lower. So the scarcity of O negative blood is typically why we're so careful with it. So we are reserving those units to kind of our high-risk patients. So we're talking about our neonates, we're talking about our oncology population, and especially we're talking about women of childbearing age. So O positive itself, though, on the other hand, is way more abundant than O negative. So approximately 40% of the US population actually is O positive. For example, I'm an O positive. My blood is O positive type. So there are some areas that might be even higher. All right. So this makes it a way more sustainable and scalable solution for EMS because we have that more available O positive than O negative. Now, here's what makes O positive safe, scalable, and field ready. And this is when things may get a little controversial. Now, many O positive donors have low levels of A and B antibodies. So this is going to kind of minimize that risk of that plasma incompatible reactions that can happen. So our estimated risk of serious hemolytic reactions, right? We're talking about serious events of hemolytic reactions. It's about 1 to 80,000. So doc, what about those RH concerns, right? So in trauma, we know that we have kind of a little bit of immune suppression. So this is already reducing the risk of sensitization. And we can administer RH immunoglobulin to kind of that potential woman of childbearing potential. So we are mitigating that risk. So in the field, O positive is kind of striking that perfect balance for us. So it's widely available, it's safe and effective, and we can mitigate the risk for certain populations that we know this could be a risk for. So this is kind of like truly providing that resuscitation that we want. Now, and this is happening even before the patients are reaching the hospital. Now, we kind of talked about the evolution of trauma, resuscitation, and kind of the power of whole blood, right? So where is blood actually being used in EMS today? Now, I want to kind of highlight two studies. So the study by Theos et al., about 84% of our pre-hospital blood transfusions are actually occurring during air medical transport, so our helicopter EMS. And in contrast, by that study, only about 12% is taking place into ground EMS transport. So that's that massive disparity that's happening in between. And another separate study by Holcomb is kind of reinforcing the trend where we're showing that pre-hospital transfusions are significantly more common among helicopter services that are already equipped with the whole products. So simply put, the access to pre-hospital blood is still very limited, and it's predominantly in the critical care transport settings. So not your average 911 emergency response that we have in the field by ground. So this is raising that important question about equity and kind of system levels questions. Why are we only delivering kind of this potentially life-saving intervention to patients, for example, who are in rural areas with long flight times, right, that helicopters are responding to at the scene? Now, in the United States, we are kind of, EMS is regulated at a state level, and that is a huge distinction, right? So the federal government don't necessarily has any say into how states want to regulate their EMS. Now we can see in this map here, all the states in red are the ones who are allowing blood transfusions by EMS clinicians. We have some states in the black color that do not allow that, and we also have kind of one yellow that is kind of limited. So this is kind of important to see. So we're kind of seeing the momentum that is building in the last decade or two about pre-hospital blood interventions. Now, very quickly here, and I think we just mentioned that a little bit, if anyone wants to throw in the chat, how many counties in North Carolina have blood available in the pre-hospital setting? And I'm talking about specifically kind of some of our ground units that have that there. So there's about 100 counties in North Carolina. How many of those do we think have blood available? If you want to throw a quick thing in the chat there, guys. 0 to 100. 20. All right, not too far off. 15. Okay. All right. I think we're close enough. So in North Carolina, and this is a map here, the EMS is regulated by our Office of Emergency Medical Services, and that falls under the Department of Health and Human Services. So like most states, our North Carolina legislation is determining what EMS can and cannot do. So currently, pre-hospital blood transfusions is not part of our standard statewide protocol, but we can see that there are lots of programs across the state. So we have clusters around the west side, or the west side, the west region of North Carolina, some down to the Fayetteville area, and some out into the coast. So the total that I have based on this map that I obtained was about 16, and that number it probably is a little bit different since I've kind of made the presentation. Now the next map, which I actually saw being thrown in the chat there, so for our Metrolina, so for us here, part of the Metrolina rack, Catawba and Mecklenburg are two counties that I can't speak for Catawba, and if anybody from Catawba is here, is more than welcome to, but I can speak for Mecklenburg. So a little bit, right? EMS Fellow, Dr. Swanson is our medical director for Medic. So I was kind of, picking his brain about where we are with blood. And the early discussions for us here didn't gain much traction with the blood banks. So that's still a work in process. And I'm going to talk a little bit more about that. And also, as we would imagine, we have funding and for the required equipment and startup costs and everything, it's still a barrier. So we're very early on into having blood available here in Mecklenburg County. So let's kind of recap real quick before we get to the end of our presentation here. So EMS is kind of that vital link to chain of survival. So we are talking about damage control resuscitation that's beginning in the field. We have whole blood that's going to deliver all the components that we want. O negative, as we know, is limited and reserved, but O positive, not as much. So now the low titer O positive carries that low risk of reaction, so about 1 in 80,000, and we can mitigate the risks of incompatibility or RH issues there. That we talked about, mostly is in the air, not the ground. And to remember that a lot of this is going to be regulated by your state, right? By our state. Now, I kind of want to talk about, we talked about the clinical promise and the understanding of early blood transfusions, what that means. Now I want to kind of talk about the reality a little bit. So this image here, I think, kind of shows what implementation often feels like, not just blood and EMS, but just, any change we want to make to a system, right? So getting blood into the field is not just about the good evidence, right? We want to overcome this kind of mountain of logistical, regulatory, financial challenges in general. So each step forward, right, it's going to take negotiation and coordination. So I kind of want to push forward a little bit so we can talk about some of these barriers into having pre-hospital blood actually available in our counties. Now, I kind of want to open up the floor once again to our chat here. I'd love to hear from the group. Who here kind of has run into some red tape or any issues with kind of this, having blood programs into the field? I don't know if anyone wants to speak up or drop some things in the chat there for us, like some examples of some of the barriers you've ran into. All right. Any brave souls out there? You want to drop it in the chat real quick? There you go. Yeah, so Union, for example, has had issues with blood bank, doesn't want to rotate or supply, startup costs for warmers, blood bank concerns. It's not EMS, but have a queue about Navant versus Atrium, got it. Startup costs. So we're talking about the financial things, logistical hurdles, things that I kind of want to talk about next here with us. Now, having blood into the field is not just going to be about that medicine, right? It's going to be a maze. So there's kind of real world red tape that, systems have to go through. So we're going to require the approval from multiple regulatory bodies to have blood in the field, and each is going to have their rule and paperwork. So these challenges is going to be kind of coordinating across multiple agencies. So we're talking EMS systems, we're talking about hospitals, we're talking about blood banks, and we're talking about public health departments and even our legislators. So finally, we kind of have to meet very strict standards as well. So we have storage, handling, and transport. That's very important. And this can vary widely by jurisdiction. Okay, so that's very important to remember. So the bottom line is, even with the strong evidence that we know that's out there in our literature, Regulatory and administrative barriers are going to remain one of the biggest challenges to kind of launch that pre-hospital blood program. Now, to successfully launch one, it's not just about the logistics and protocols, right? It's going to be about people. So this is kind of where the community and engagement of stakeholders are going to become essential. So to move a program forward, you're going to have to buy in from, for example, all these organizations I put here, just in the thought of, for example, Mecklenburg County, right? So we have MEDIC, we have our county regulation, we have a blood bank example, we have the 2 hospital systems, we have our Metrolina trauma rack, right? All the things that are very important. But got to remember too that this is not just about the organizations, right? This is going to be about the community. So we often going to have to rely on public trust, which is very important. We're going to have to talk about donor support, and in some cases, even local funding from our communities themselves, right? So we're going to have to be transparent. We're going to have to communicate, and we're going to have to show the value in a public way of what it means to actually have blood, and not just in our urban counties, for example, but also in our rural areas that would benefit from having that blood. I kind of want to dive just a little bit deeper into our logistical challenges too. So I want to talk about a little bit about blood storage and transportation, even timely deployment in the field, and kind of how those things can be an issue, and some ways that systems have overcome these challenges. So this image here, I'm kind of showing you a blood supply chain. So we're moving from donors to temporary and fixed collection sites, right? We're talking about the production centers, so our blood centers. We're talking about the kind of making the components and testing. We're talking about storage, and then we're talking about moving that into the demand nodes, which are going to be the hospitals, and then we're getting that into the patients. But if you see here, these classic systems, right, these traditional systems do not have EMS part of that traditional flow at all, right? So this is going to be a hurdle because our blood banks, they have strict policies on who they supply, which makes sense to me. So they're going to prioritize hospitals. We have concerns about hemovigilance, right? We don't want to deplete the existing pool of blood that these centers are already working very hard to obtain, in the hospitals and the centers, et cetera. So successful programs, for example, kind of have created even, for example, dedicated blood drives specifically to support pre-hospital use. And this kind of makes it clear that it's not about competing with the hospitals. It's about extending the reach of the care, right? Now, another very important part of the logistic of blood for us, right, is kind of that cold chain management. So blood has to be maintained at about 1 to 6 degrees Celsius. We're going to use portable coolers, for example, these 2 that I decided to show here to kind of remain compliant with our standards. And if done right, we can have blood remain viable up to 21 days in the field. Now, keeping it at the right temperature through transport and storage is going to be that constant logistical challenge that the EMS systems are going to have in order to kind of make sure that the blood is safe to be administered. And it's not just about cooling the blood too, right? We have to kind of warm it before it's safely transfused. So on the left here, we're seeing an image of some of those blood warmers and how much they can cost. And we also need to have thermometers in order to keep that kind of reliable temperature monitoring throughout when the blood is out in the field. So there's no microwave here, right? There's no guesswork. We have to have very strict protocols to make sure that what we're giving is safe and effective to our patients. I promise you guys, I'm almost getting to the end here. So getting the blood to the right patient also means kind of that fast, smart deployment strategy that we can have. So I, for example, did my residency at Prisma Health in Greenville, South Carolina, where I did my emergency medicine training. And Howard County, for example, EMS, they also have their blood in supervisor vehicles instead of the ambulance itself. So this kind of plays into the role of that dynamic deployment of your resources based on call data. Okay. So this is very similar also how we handle kind of the high risk interventions that are not used as often, for example, like RSI. So we have those specialized teams within our organizations that can be positioned where the blood is most likely to be needed, but that's going to vary, massively by county to county. So we can use kind of that predictive data and strategic placement of the blood in order to get it faster and safer and more efficiently to our patients. So we have to be kind of proactive with this resuscitative model in trauma care in the field. Now, inventory management, just very briefly, we have to track the usage, expiration, restocking of the blood products. So some places like San Antonio EMS are rotating their unused blood back to the hospital every 14 days and no costs to the organization. Whereas, for example, a system like Broward County EMS, they're paying for all the units, whether they're used or not. So in both cases, the investment is considered worth it. All right. Now, very briefly here, I'm not going to spend too much time on this, but the question that I have for the group is, what do you think the estimated annual cost is for pre-hospital blood? And I'm just going to go ahead and jump into it, okay? So I can give you guys some time back and leave time for questions at the end. So, I don't know any EMS systems that are swimming in money or any systems in general that have money to just give out. So it's going to come with a hefty price tag, right? Both up front and to keep it alive. So San Antonio EMS, for example, they're spending about $75,000 per year with approximately 8 units carrying blood, and approximately 6 units are used every 2 weeks. Maryland County, or Maryland's Howard County, for example, with EMS, their startup cost to equip every vehicle was about $7,000 plus all the other supplies. So it's about $600 for each unit of blood. And then you have all the warming equipment, the disposable things, and the training to the EMS clinicians, so our paramedics. So the annual cost can range anywhere from $50,000 to nearly $100,000 every year that's going to come out of budgets. Now, most importantly, too, you cannot talk about the cost of things without thinking about reimbursement. So EMS agencies are relying on transport-based billing in order to kind of pay for the cost of things. So this means that every intervention, like our blood, is going to be funded through the ambulance fee schedule. So right now, only certain blood products are reimbursable, for example, through CMS, and is not covering the true cost of what it means to carry blood. So there have been some changes recently. It's kind of proposed by CMS that lots of our organizations have opinions and statements on it, that they want to kind of expand the reimbursement to include all FDA blood products that could be not just the low titer O positive. They also want to increase the available funding so that EMS systems can actually afford to have that. And we also want to adjust the reimbursement rates to reflect the actual real cost of delivering these life-saving treatments. So we have to make it financially sustainable in order to have the blood out into our patients. Now, financial planning itself, I'll be very brief about this. So we're going to have strategic budgeting. You have to apply for federal, state, and local grants. We have to explore cost sharing. So for example, if you have a region who wants to invest together in order to explore the cost of that, you're going to have to partner with hospitals, right? And businesses, for example. You're going to have to worry about that maybe community-based funding. And you can use models that are out there that are published in the internet about sustainable and collaborative ways in order to make it sustainable, like I talked about. Now, I promise I'm done about talking all the hurdles, right? But there's a couple more I just wanted to highlight instead of diving into a lot of details. So to safely even run, besides all the things I just talked about, we also have to have that robust training and credentialing of our EMS providers, right? Our paramedics and our systems. So every provider that's going to, come in contact with that blood to administer in the field is going to have to know how to store, handle, and administer that blood. And that's not going to happen without kind of that comprehensive training program, which is going to take time of those providers in your agency already to be able to learn how to do it. The next thing is documentation, right? This is going to be key. So, the medics are going to have to understand how to chart transfusions and to kind of stay compliant with that billing and quality review of the blood that you're going to be administering in the field. So we also going to have well-defined protocols of what to do. And I didn't even touch base into that. Like, what are some ways that people are meeting the criteria in the field to give blood? And you're going to have QA and QI processes to monitor the safety and to improve performance when needed. So for certain systems that already exists. So you have urban counties who have access to the personnel needed to run good QI and QAs. And then you have rural agencies or smaller counties that are not necessarily going to have the access to that. So those things also matter. So very briefly here, guys, to kind of conclude everything, implementing blood into our trauma systems is not, it's not a small feat. But it has the potential to transform trauma care. So we're bringing kind of this life-saving intervention to the scene where we have shown that we can improve outcomes, where seconds are mattering their most, right? So you're going to have regulatory, logistical, and all the barriers we just talked about, but there are ways to overcome it, and systems have overcome these challenges. So it's going to rely on collaboration, okay? So we have our EMS providers, we have our hospitals, we have our blood banks. So all the stakeholders that are important in order to make this happen. Now, the ongoing evaluation too, if we do implement this into your system, is adapting and improving it, and you have to scale it to the fact of your EMS. There's a common say, right? If you've seen one EMS system, you've seen one EMS system. So things are going to vary widely, even from counties beside each other. So that's important to remember. And guys, I want to bring something up that I didn't even mention at all, right? Blood is not just for trauma, all right? So we have also medical things that are happening in the field. So we have our upper GI bleeds, our lower GI bleeds. We have our postpartum hemorrhages. We have our abnormal uterine bleeding. So just hemorrhagic shock in general, right? That you can improve outcomes also by having blood available to those patients. So it doesn't just become about trauma at that point. And I didn't even go into that side of the field at all. So I kind of want to, leave this off with a call to action for us, right? If you want to, it's about engaging. For example, the first person that I can think of is your EMS medical director. That person, has the training, has the understanding, and has the networking in order to begin kind of that process. Now, we're also going to have to push for policy changing and funding, and that's going to be a big deal. So, the future of our trauma care is not just the trauma bay and our great surgeons and our great trauma teams and our regionalization of our resources, right? It's also going to be in the field, and we have that trend that, we're wanting this to be out more and more into the field. So it starts with us, right? It starts with us in EMS, and, that's a very important thing to remember. Very briefly, a couple of the resources that I used in order to, make this lecture. I want to highlight the North Carolina Prehospital Regional Blood Coalition. Lots of great information into their website, essentially about everything that I kind of talked about. So there's a great resource there for us if you want to look more into this. And then just like everything in life right now, everything ends in a coffee shop or Uber ride always leaves with a tip screen. So with that, I'm happy to take any questions that the group may have. So thank you so much.
Great talk, Dr. Nagy, full of information. I learned a lot from a historical perspective. Questions from the group? Surely we've got some out there. Comments in the chat, a lot of good participation. Anybody have any questions? Anybody from the audience, feel free to speak up. Scott.
Hopefully you can hear me. My signal is not too great right now. Dr. Nagy, there's 100 counties, like you said. So that means 100 plus EMS agencies, and it's actually more like 120 plus flight services. Is it possible or even feasible for us to have that many pre-hospital services with blood on their ambulances?
If it's possible, I absolutely think it is. I mean, that would be a huge, feat in order to have a whole state be able to have that available. I think that at that point, it would be, our policymakers at the state level would really have to buy into this. So lobbying is going to be a very important thing, because then if we're going to, like I said, if we're going to make this a state protocol, right, that we want our whole state to have that available, then we're going to have even more funding that is going to come to help our EMS agencies to set this all up. I think the scale is massive to get to that point, but is it feasible? I think so. I think it would take a lot of time, but it could happen. It just depends. Good question. Yeah.
The question in the chat. Let's see here.
Looking into it right now.
Yeah.
Let's see. I know that the military is transitioning to administering 2 grams of TXA in the field within the last year. Are there studies that show evidence that 2 grams is better than 1 gram? I can't think of anything off the top of my head right now. I don't know if there's any other, any other people out there that would know the specific answer to that question. But that's a very good question. I unfortunately, I just don't know the answer to it. And I apologize for that. But I can definitely get back to us, and I can look that up. And let's see, it would be also help to help more emergency medicine representation on the North Carolina Medical Board. Yeah, I mean, being at those tables that make decision is very important. So I agree with that statement too. Having more of us being present when these decisions have been made at the state level, it's very key to kind of moving this forward. All right, guys. So if anybody has no other question, I'll give time back to y'all so you can enjoy the rest of your day. And then please email me with any questions or concerns. So thank you all.
Thanks everybody for joining. Great talk. Appreciate your input.